Hello, I'm Dr. Asma Sadaqat. I'm one of the mentors in Study Medic. So today we are going to start our topic of early pregnancy. It's a YouTube series we are actually starting for the students who are appearing for MRCPI Part 2. And there will be some questions which will give you an idea that how the usually questions in single best answers format comes in the exam, and how we have to encounter those, and what will be the answers with explanations in these sessions we will describe. So this is to make you motivated for this module. So you'll have to win in your mind and you will win in your reality. So whatever you think in your mind, how you believe in yourself is going to make you through the single best answer questions which you're going to encounter in MRCPI exam. So the pattern usually comes like in the 4 best questions, and there is a scenario which they give. And in the early pregnancy module, there are lots of topics which includes ectopic pregnancy, hyperemesis gravidarum, and gestational trophoblastic diseases containing choriocarcinomas and other neoplasias as well, and others topic like miscarriages. So these are very, very important topics when you're considering this module. Though in MRCPI exam, there is no module system, but you can prepare your topic by module way if you follow Study Medics, so that you come to know that what is a module and what topics will be there in that module. So this helps you categorize yourself in different, easily going through those categorization of the topics. So today's topics will be early pregnancy containing ectopic miscarriages and hyperemesis with gestational trophoblastic disease. So the first question, sometimes the question, so these questions are going to give you an idea how the exam questions will be like. So HIV patient met hepatologist and and was diagnosed as an ectopic pregnancy. So in this case, what is the contraindication of methotrexate? So the 4 choices are given. One is the size of 30 ml, beta HCG of 1000, and fluid of 100 ml free fluid, and in option D is HIV. So the answer here will be D. So the question, when it started, gave you a hint that the patient with the ectopic pregnancy has gone to the hepatologist. So there can be a long scenario which can come in your exam, but the main question ending was, what was the contraindication? So this is mentioned in the guidelines, and it says the contraindication include pre-existing blood dyscrasia such as bone marrow hyperplasia, leukoplakia, thrombocytopenia, or significant anemia, and those patients coming up with acute or chronic conditions like TB, HIV. So here you got your answer of HIV and TB, and then your answer matches here with the D. Now, the next question is a 32-year-old woman presented with left eyelid fossa pain, having pain, provaginal bleeding for the 3 days. When you did the ultrasound scan, you did not see any intrauterine gestation sac, and endometrial thickness of 8 mm was noted with minimal free fluid, and no adnexal masses were seen. When you did the HCG, it showed 1500 international per liter. So what will be the best management option in this case will be? In this case, the best option will be beta HCG 48 hours in 1 week, or in 3 weeks, you do the pregnancy test, or you do the diagnostic laparoscopy. So here you will find out, you will have to follow this table. So in this case, you will have to see that when to follow the expectant management, medical management, and surgical management. So in expectant management, you see the beta HCG is less than 1500 when the mass is less than 3 centimeter, and when the patient is not having any pain and no evidence of rupture. In case of medical, then the beta HCG is lying between even 3000 to 5000, but having normal CBC and liver function test and your electrolytes, and there is no evidence of rupture or pain, and there is no contraindication for methotrexate, then in that case you can start off with the methotrexate. For the surgical, if you have the beta HCG of greater than 5000, or any of the beta HCG level, but you see the live pregnancy or patient is having symptoms, so in that case you'll have to go for the surgery. Now in this case the option is D, because the patient is 32 years presenting with the symptoms, which is left iliac fossa pain and PV bleeding. So you did not see any gestation sac, so you cannot measure the sac size according to the criteria given in expectant or in medical management. You see a minimum free fluid. So beta HCG is 1500. So when I said that in surgical management is going to be suitable for the patient with any beta HCG but having symptoms. So this patient is having symptoms, you're going to go for diagnostic laparoscopy to make your decision for doing the procedure. So the next question is a young woman is coming at the age of 26 year with heavy bleeding. There is a history of past medical abortion with GP. Now she's developing tachycardia and low BP at 6 weeks. We did the ultrasound scan. Ultrasound showed 8 weeks intrauterine pregnancy. Now what is the preferred management? So the options are ERPOC, misoprostol 400 mcg, mifepristone followed by misoprostol, or misoprostol 1000 microgram followed by 600. This is a very important question. So you can see that most of the time we can follow the medical management when the pregnancy presents below 9 weeks, but here we cannot go with that because there is a past medical abortion with GP. And the second thing is the patient is developing tachycardia and low BP. So this is the time when there is hemodynamic instability going on with the patient. So we need to perform evacuation immediately. So the option is A. Now, the question number 4 is a patient is HIV with no detectable viral loads. Has been diagnosed as ectopic pregnancy, came to hepatologist. Which one of these is contraindication for methotrexate herb? So it's almost like the same question, but they're asking about the contraindication for the methotrexate. Here the options are quite a little bit different, showing free fluid 100 ml, HIV, gestation sac of 30 mm, mild pain, and beta HCG of 1000. Now here, this is going to be a little bit confusing because contraindication is also HIV and free fluid 800 ml. Here in this case, the best option would be A, because the fluid presence is one of the pointing factor where we have to do the laparoscope as the patient may be developing signs of rupture due to the growing ectopic pregnancy. So the best answer in this case will be answer A. Now let's go through the important points of methotrexate, as most of the questions are coming on this part. So it usually is a safe and effective treatment for ectopic pregnancy management. It's a folic acid antagonist that inhibits DNA and RNA synthesis and can be considered when beta HCG is less than 1500, but usually we do it between 3 to 5000, and especially when there is an adnexal mass which is not greater than 35 mm. And a candidate for the medical management with methotrexate should be hemodynamically stable with no evidence of acute intra-abdominal bleeding and not in severe or persistent pain. Now, contraindication we already know, we cannot give in cases with the patient having blood dyscrasias or having acute infections like TB, HIV, or other immunodeficiency syndromes, ulcers of any kind in GI or in oral cavity, breastfeeding, or with any other concurrent vaccination with live vaccines has been given to the patient. Now, this is an interesting question, and it asks about a patient which had a suction and evacuation after molar pregnancy. Now, HCG normalizes in 8 weeks. How to call the patient for follow-up? So this is a simple question. So you need to go through the gestational trophoblastic diseases guideline, which has been given by HSC. So it says it normalizes in 8 weeks. So this is the key point. So it goes normal in 8 weeks after the procedure. So what kind of follow-up is going to be there? So this is going to be confusing. Follow-up after 6 months after suction and evacuation, or follow-up 6 months after normalization of levels. So here, C is also confusing in the case that it gives 8 months and follow-up 48 days after normalization of levels. So the best answer would be, when you see this pathway, it will be A, after suction and evacuation, only follow-up for 6 months. So patient with a complete herediform molar pregnancy, you do the evacuation, monitor beta HCG level weekly on the same beta HCG platform until normalization for 3 weeks. We got 3 weeks consecutively weekly readings. and that's coming up normal. Now, if it was less than 8 weeks of duration, so you will only monitor for 6 months. So that means you did the section evacuation, it normalizes after section evacuation. So you only need monitoring for the beta HCG level for 6 months after the procedure. Otherwise, you will monitor for 6 months post normalization until it gets normal. Only then, after the third value of the normal value, you're going to go for further monitoring of beta HCG for 6 months. Now here, the question number 6, a woman presents at 8 weeks gestation in a first pregnancy with severe nausea and vomiting for pregnancy. Now we did the TFTs and it shows hyperthyroid functions. The TSH is very low and T4 is coming up 20, which is quite high. What is the most appropriate management plan? You commence the carbimazole and check TSH receptor antibodies. You commence the PTU and repeat TFTs in 6 weeks. You support treatment for the nausea, vomiting symptomatically and check TSH receptor antibodies, or you do supportive management for the nausea, vomiting and repeat TFTs in 6 weeks, or you only give supportive treatment for nausea, vomiting in pregnancy. So this is also a very important question. And here you need to know about the Graves' disease, how it presents, and it usually causes difficulty in differentiating it from the gestational hyperthyroidism, which affects 1 to 3% of the pregnancies and usually occur because of the stimulation of the TSH receptors by beta HCG. Now, the answer here would be C. This is supportive treatment, and then check TSH receptor antibodies. We want to see whether this is physiological or whether this is because of the Graves' disease. So here, it is the Graves' disease, which is actually presenting in pregnancy, can be difficult to differentiate from gestational hyperthyroidism. For this, you're going to do free T4 levels, which are actually raised in both conditions. But when we are going to do TSH receptor antibodies, which are usually positive for Graves' disease, so it is going to differentiate the Graves' disease from the hyperthyroid situation, which occurs in nausea and vomiting in pregnancy. And usually can be misdiagnosed as a Graves' disease, or Graves' disease can be missed. So when the patient is presenting with hyperparesis, you can also give supported treatment with nausea, vomiting. You do the T4 and TSH level test. If there are some abnormalities coming, like T4 raise, you go for antibodies. Now, the 34-year-old woman visits her GP at 6 weeks gestation in her pregnancy and second pregnancy with mild symptoms of nausea, vomiting in pregnancy. So she had severe NVP, that is nausea and vomiting, in her first pregnancy requiring hospital admission, and now is concerned that her symptoms will worsen. Now, what is the most appropriate advice from the GP when she comes? You're going to admit the patient for assessment and treatment. You give the outpatient hospital attendance for IV rehydration. You reassure that severe NVP is unlikely to recur, or you give treatment with cyclizine if symptom worsens, and you give treatment with ondansetron if symptom worsens. So now the important point is she's 34-year woman in her second pregnancy, in 8 weeks of pregnancy, only with mild symptoms. She has a previous history of hyperemesis, so there is going to be recurrence, but it doesn't mean you're going to admit or give, outpatient hospital attendance for IV rehydration. So these two things are not appropriate. And reassurance is also not good, as she's presenting with mild symptoms, but the symptoms are there. So the best thing is cyclizine, which is the antiemetic. And E option is not suitable because ondansetron we usually consider as third line. So the first line is cyclizine. The option goes best here is D. So we see here. Next slide. Answer is D. That if we follow this algorithm, so we give doxylamine and pyridoxine, 1 in morning, 1 in afternoon, and 2 at bedtime. And if it is not getting up and, with these symptoms, the dose, then we give the promethazine or prochlorperazine or prochlorperazine, 3 milligram, or cyclizine. So cyclizine is there in our options. So we're going to go with treatment with cyclizine if symptom worsens. Now, This is important, a very common question. Usually these incidences might come, so you need to understand that what percentage of women with hyperemesis in early pregnancy experience transient hypothyroidism. So you should know that how we can see that what is the transient hypothyroidism usually occurs physiologically in pregnancy, and um, how common is the Graves' disease. So the percentage is 50%. The 50% of the women can have transient hypothyroidism, so not everyone should have an investigation for um, Graves' disease. So in 60% of the women presented with hyperemesis gravidarum has been noticed to have hypothyroidism. Why? Because HCG and TSH level has a common beta receptor um, connectivity. Because of this, increased level of the HCG causes increased level of the hyperstimulation of the receptor side, causing increased TO levels. High concentration of progesterone, ACTH, and leptin is also associated because of this phenomena due to hyperemesis. Now, question number 9 is a 26-year-old woman has presented with left iliac fossa pain and has a 6 weeks period of amenorrhea. The patient is clinically stable. We did the scan and we found left-sided ectopic pregnancy. There is a 2 into 2 into 2 centimeter pool of free fluid in the pouch of Douglas, and the serum beta HCG is about 3,500. Now, what is the recommended treatment? Now you see a mass on the left side. You see the beta HCG going up greater than 35, and you have a pain. So in this case, the options we have are left laparoscopic self-injectomy if the contralateral tube is healthy, or salpingotomy, or left self-injectomy via a laparotomy, methotrexate, or repeat beta HCG levels and manage accordingly. So again, we're going to follow the same protocol of the ectopic pregnancy table. So as this patient is having high levels of beta HCG levels, you see the pool of free fluid in the POD, and you find a mass, and you have symptoms of left iliac fossa pain. Sometimes you can also find some blood pressure, hypertension as well. But in this case, we are going to give her option number A, as this patient is clinically stable, so we cannot go for the laparotomy, but with the left laparoscopic self-injectomy if the other tube is healthy. So in the presence of the healthy tube, we go for self-injectomy. If the other tube is not healthy, then we go for laparoscopic self-ingotomy. And we do laparotomy in a case when she is clinically unstable. So here, the important point was clinically stable patient, though there are fluid in the POD. Now, this was the table we followed. She was coming up greater than 35 minutes, so she was not fitting here. Why she was not fitting in medical treatment was because beta HCG level though was 3,500, and the mass was less than 3 centimeter, but she was having fluid in the POD, where we usually do not give methotrexate. So this is a chart of the pregnancy of unknown location, and everybody should go and see see this PUL chart. It gives us when the patient presents with pregnancy of unknown location, then how you go about it. With stable patient, you do the serum beta HCG at 0 and 48 hours, and if it is greater than 60%, so that's a live pregnancy, and if it is not rising, it's less than 66% rise, then it can be pregnancy of unknown location. And if the patient is hemodynamically stable with and experiencing pain, you do the beta HCG level at 0 to 48 hours, or you can also admit the patient and then you repeat the beta HCG levels and you do the TVS scan to see if this is the patient on ectopic pregnancy, can be given the medical treatment or can be given the surgical treatment. And with the unstable patient, you suspect the ectopic and arrange for ultrasound scan and do the surgical management according to the levels of the beta HCG and scan findings. Now, a woman has undergone surgical management of the miscarriage and a partial molar pregnancy has been confirmed. Referral to the specialist center is advised. How would you follow her up? So, in this question, you need to know about what actually is the pathway of the partial molar pregnancy. So, number A is patients with PHM should have their serum beta HCG level done weekly until normalization, and one further confirmatory beta HCG is performed 4 weeks later. Or patients with PHM should have their serum beta HCG monitored twice weekly until normalization, and one further confirmatory beta HCG measurement is performed 3 weeks later. Or this, we do it beta HCG monitoring fortnightly until normalization, and one further confirmatory HCG measurement is performed 2 weeks later. Or patient with PHM should have their serum beta HCG monitored weekly until normalization. So the best answer here goes is A, because this is according to the guideline. Patients with PHM should have their serum beta HCG monitored weekly until normalization, and one further confirmatory HCG measurement is performed 4 weeks later. So this is the chart you can see through the gestational diabetes, gestational trophoblastic disease guideline by the HSC. Now the 11 questions, it again tells you about the percentage. So a woman has been diagnosed with high-risk form of the gestational trophoblastic neoplasias. So what you give it multi-agent chemotherapy. What is the expected cure rate? Everybody should know and have an idea that gestational trophoblastic have the cure rate of about 95%. So the answer goes D. The cure rate for the woman of a score of less than 6 is 100%. That is those women who are giving methotrexate, and the rate for women with score of greater than 7, the women who receive EMACO, etoposide, methotrexate, and adenomycin receive 95% of the cure rate. Now, in question number 12, a woman underwent medical management of miscarriage, but no specimen was sent for histological analysis. What would be the advice to the patient following this procedure? Number A, do nothing. Number B, if your periods doesn't return within 6 weeks, do a hormone pregnancy test. Or number C, perform a home pregnancy test in 1 week. Or number D, perform home pregnancy test in 3 weeks. Or number E, perform a home pregnancy test in 5 weeks. The best answer goes with D, because you need to perform UPT after 3 weeks to check whether you have a failed medical management for a failed pregnancy or you need any other kind of the treatment. Now, the other question is a patient with 8 weeks of amenorrhea with failed medical management. She admitted for surgical evacuation. Now, when we were doing surgical management, when should we give oxytocin? This is also a very important question. Number A, always. If blood loss exceeds 50 ml or 150 ml or 250 ml, or if life-threatening bleeding is encountered. So in these cases, when you're doing surgical evacuation, you don't need any specificity type of the ml where you have to give the oxytocin, but you need to give it when you're suspecting bleeding. So the answer is E. Excessive vaginal bleeding can be associated with molar pregnancy, and consultation with a senior surgeon should be done. Oxytocin infusion should be commenced in a case when there is an excessive bleeding, because it may be because of the molar pregnancy, and the need for the oxytocin infusion is weighed up against the risk of the tumor embolization. So you have to be very, very, very particular and concerned and involve the senior at this stage. The very important questions relevant to the molar pregnancy comes is a woman has had an ultrasound scan and the possibility of a molar pregnancy with a coexisting twin has been raised by the sonographer. The woman is referred to fetal medical center for further investigations. So what would be the most appropriate investigation? That's also a very, very important question. And the option A is FPS for fetal HCG levels of the suspected molar pregnancy, or karyotyping of the suspected molar pregnancy, or karyotyping of the mother, or MRI scan, or do the serum beta HCG level. So it's a part of the green top guideline, which is missed in the green top GTD guideline of the HSC. So you can, we need, when there is a twin pregnancy and one is a molar, so you do the karyotyping. So the answer goes B. So in case of combined molar and viable pregnancy, advice needs to be thought to fetal medicine unit and twin pregnancy where there is one viable fetus, you need to tell the woman regarding the outcome of the gestational trophoblastic neoplasia or increased risk of perinatal morbidity, and prenatal invasive testing for the fetal karyotype needs to be done in this case so that we can see that the coexisting normal twin is fine or have a partial bone. Now, the next question is a 25-year-old woman attends early pregnancy unit with vomiting and bleeding. An ultrasound scan is performed, which is strongly suggestive of a molar pregnancy. What is the optimal method of uterine evacuation? Number A, medical evacuation with methotrexate, or medical evacuation with mifepristone and misoprostol, or medical evacuation with oxytocin, suction curettage, or total hysterectomy. So here, women with EPAC, bleeding and vomiting. So you have a molar. So what to do now? So I've given you the option. The best answer is D, which is suction evacuation, and molar pregnancy is diagnosed, you go for S&E. Now, the next question is a 30-year-old woman attends the early pregnancy unit with a positive pregnancy test and some lower abdominal pain. Now, her last menstrual period was 8 weeks ago, but her menstrual cycle is irregular. You do the TVS scan, and there is a gestation sac with fetal pole and yolk sac, but there is no heartbeat. The CRL is 6 mm. What is the correct course of action? It's another form of the ectopic pregnancy question, which might come in this way. Number A, inform the woman that she has missed miscarriage and arrange surgical evacuation. Number 2, inform the woman that she has a missed miscarriage and arrange medical evacuation with misoprostol. Number C, inform the woman that she has missed miscarriage and arrange medical evacuation with mifepristone and meso. Number D, inform the woman that the pregnancy appears normal and no further intervention is required. Number E, inform the woman that the viability of pregnancy is uncertain and arrange for further scan in 7 to 10 days. Now here, this was an early pregnancy unit. She's coming. The key points are positive pregnancy test with pain, LMP 8 weeks ago, and now there is CRL of 6 mm with no fetal heart and fetal pole. It's a clear-cut question where you have to follow the guideline that what we have to do with missed miscarriage woman when she's coming with CRL 6 mm. So you will have to follow this guideline. It says when there is CRL or embryo greater than 8 mm with no cardiac activity, that's a miscarriage. And if there is greater than 25 mm of gestation sake, no embryo yolk sac, that's a miscarriage also. So in this case, 7 mm, we have kept the cutoff, and this CRL is 6 mm. So the best answer will be E, where we have to inform the woman that viability of pregnancy is uncertain, and we will have to arrange another scan in 7 to 10 days because it hasn't reached 8 mm or 25 mm of gestation sac. Now, the next question is a woman who has had left salpingectomy previously for ectopic pregnancy has now been diagnosed with ectopic pregnancy in the right fallopian tube. So she had left salpingectomy done. Now she has come with ectopic in the right fallopian. A laparoscope performed, surgeon opts for salpingotomy because she doesn't have any healthy tube. What is the possibility she is going to require further treatment because of treatment with methotrexate or salpingectomy, resurgery, where we can do the salpingectomy or methotrexate? So this is also a very important question, and the answer is D. That is 1 in 5 women, 20%. 1 in 5 women may require methotrexate treatment because of salpingotomy or may require resurgery because of salpingectomy. Now, the question number 18. The patient is the 7-week amenorrhea come with heavy bleeding. The ultrasound scan is done showing empty uterus with no RPOCs. ET we did, and that shows 25 mm. OS is open. What is the next step here? Are we going to admit and observe or do any RPOC, or we're going to do nothing? So here, the answer is B. We're going to do ERPOC as endometrial thickness is 25 mm. So it's a big RPOCs is still there, and you're going to do the ERPOC of the patient. Now, question number 19. A woman of age 26 years presented with severe abdominal pain in emergency. Her examination shows vitals of 80-60 BP. Heart rate is increasing, that is 120 BPM. Pelvic scan shows right ovarian complex max with moderate fluid in POD. Beta HCG is 3000. CBC shows HB of 7, so it's dropping. So the most appropriate step. Now this woman is coming up unstable, BP 80, 60 and 120 heart rate. Now she's having severe abdominal pain. She has beta HCG of 3000 and right complex mass with moderate fluid. So that patient, are you going to do laparoscopy, laparotomy, inform consultant and arrange for medical management and call to surgery? So the best option in this will be B, because B, which is laparotomy, because the patient is unstable, cannot go for laparoscopy. So a laparoscopic approach to surgical management of AP is preferred, but a woman who is unstable due to intraperitoneal hemorrhage should be treated by the most expedient surgical method, which is laparotomy. So now let's go towards the last question of our presentation. This is primary gravida, which is coming at 8 weeks with hyperemesis gravidarum. Now, when this woman comes, her ketones is above 4+, and ALT is going up high like 100, and AST is going up high like 150. Now, what is the next step of management? Are you going to give her IV fluids plus antiemetic plus screen hepatically? Or are you going to go for IV fluids, antiemetics, or call hepatology department? Are you going to go for IV fluids, antiemetics, or follow LFTs in 3 months? Or you're going to go for IV fluids plus antiemetics? So here the option will be A, that is because once the patient gets admitted, we are going to go for electrolyte function test, serum electrolytes. Then as the patient is having epiremesis, which is associated with weight loss, ketonuria, electrolyte imbalance, and also hepatic dysfunction, so we are going to see ALT, AST. So ALT pattern will be elevated, AST will be also elevated, and low albumin, and there will be elevated bilirubin due to malnutrition and catabolic changes. So we're going to go for the hepatic screen. So IV fluids, antiemetics, and hepatic screen to see, is it the changes because of hyperemesis, or do we have other things in mind? So the option is A. Thank you so much. For this was the session regarding early pregnancy module containing topics like miscarriage, ectopic pregnancy, gestational trophoblastic diseases, and hyperemesis gravidarum. Hope it helps you out in preparing your questions, quest, and to understand MRCPI written exam for the MRCPI upcoming exam of 2025. Best of luck. Thank you.